and I'm currently a lecturer from the University of Hong Kong as well. I'm delighted to welcome you to today's ASCVD A to Z of cardiovascular pharmacotherapy webinar, the LPA challenge in primary prevention, who to screen, why it matters, and what to do next. And it is my pleasure to be here today moderating this section. Elevated lipoprotein is one of the most prevalent yet under-recognized contributors to ASCVD risk. Today, our goal is simple: to give you clear, practical guidance you can apply immediately in your clinic starting from tomorrow. We are joined by an outstanding multidisciplinary panel, Professor Alberto J. Lorenzetti from Argentina, immediate past president of ISCP and long-standing member of the board of director cardiologist, lipidologist, and co-director of DAMIC Medical Institution in Córdoba, Argentina. Welcome, Alberto.
Thank you. It's my privilege to be here.
And we have Dr. Wang Jialuo from Singapore, senior consultant endocrinologist, head of the lipid unit at Changi General Hospital, where she established the hospital's lipid service back in 2019. She specialized in metabolic disorder, including obesity, dyslipidemia, atypical diabetes, and severe insulin resistance states. She is a graduate of the Imperial College London with international fellowship, and she is an award-winning researcher with multiple publications on dyslipidemia and lipoprotein A. Welcome, Dr. Lo.
Thanks, Franco. Thanks for the kind introduction.
And last but not least, Professor Dave L. Dixon from USA. He is a clinical pharmacist in preventive cardiology with research spanning on cardiometabolic disease, guideline implementation, and cardiovascular risk management. He is a McFarlane Professor of Pharmacy and Chair of Pharmacotherapy and Outcome Science at VCU, Professor of Internal Medicine, Cardiology. He has authored more than 160 peer-reviewed papers, contributed to major ACC and NLA guidelines. He is also an associate editor for the leading pharmacy and lipidology journal. Welcome, Professor Dixon.
Thanks so much for having me.
Thank you all for being here. And before we begin, this section is being recorded and will be available on the ISCP webinar website from next week. This webinar is an independent activity run by ISCP, and any supporters have had no influence on the content of the program or selection of the experts here today. Please submit your question anytime through the Q&A box. We'll address as many as possible during the live panel sections. This is to be an interactive section, and we will be introducing some polls throughout the section. Please take a moment to answer, and it helps us to tailor this discussion to your practice. And at the end of the webinar, you'll be invited to fill in a feedback survey. It will only take us a few minutes of your time, and the information you can provide is very valuable to us. It is anonymous, so please complete as soon as we finish here. So here is the agenda for the 1 hour-long section today. We have a welcoming introduction just now, and then we'll followed by a lecture by Professor Alberto Lorenzetti for 20 minutes. And then we will discuss a case and two. And finally, we'll have a panel discussion and question and answer with our international panelists and live audience. And finally, we will be having a closing remarks and also some take-home messages from our expert. Before giving the word to Professor Lorenzetti, is a quick reminder to today's key learning objective. By attending the webinar, we hope that you'll be able to describe the unique structure of lipoprotein A and explain its causal role in atherosclerosis and distinguishing its risk pathway from that of the LDL. And we hope that you can identify the specific high-risk patient population recommended for LPA screening in the primary prevention setting according to the current international guidelines. We hope you can apply the LPA measurement as a risk-enhancing factors to refine the 10-year ASCVD risk assessment and guide the intensity of preventive therapies. We hope you can evaluate the limited efficacy of the current therapies in managing the elevated lipoprotein A and summarize the evidence for aggressive management for all other modifiable risk factors. And finally, you would be able to discuss the mechanism and trial status of the emerging targeted lipoprotein A lowering therapies and their potential future roles. So it's quite a bit to cover, so let's get started. To set the stage, I would like to invite Professor Alberto Lorenzetti to begin with an overview of why lipoprotein A is such a powerful cardiovascular risk driver and why we continue to miss it in primary prevention. Professor Alberto Lorenzetti, please.
Thank you, Professor Chen. Could you see my screen? Is everything okay? So the topic for today is the Lp(a) challenge in primary prevention, who to screen, why it matters, and what to do next. These are my potential conflict of interest for this presentation. So, protein A, Lp(a), was discovered in 1963, long time ago, by Karl Berg, by chance, like many things in medicine, absolutely by chance, because he was searching new serum type in the plasma. So lipoprotein A is now probably in the top of the topics with a huge interest for the cardiovascular doctors, but in my vision is a long, I would say an old foil. So this is the structure of the lipoprotein A. Basically, it's a particle like LDL, linked by the disulfide bridge with this structure named ApoE, glycoprotein chain of multiple kringles, 4 from number 1 to number 10, with the particularity that the kringle 4 number 2 may have different number of copies from 5, 4 to more than 40, given to this lipoprotein the particularity of being very polymorphic with a lot of isoforms. Also, lipoprotein A is the major transporter of oxidized phospholipid in plasma. There is a huge interest in lipoprotein A nowadays, but you can see here the number of publications from PubMed since the discovery up to today. Specifically related publication, we have now more than 11,000, with a peak in the middle of the 90s related to the discovery of the relationship, the genetic relationship of Lp(a) with cardiovascular risk. And nowadays, after several years with no so much movement in this area in the earlier in these decades, in the 2 last decades, nowadays there is a really an intense movement in terms of publications, research, etc. Mainly due to we have now specific drugs in development. So this is a geographical and ethnical distribution of Lp(a). I would say more than 50 milligrams per deciliter. That is a cutting point for risk. In terms of nanomole per liter, we can consider 125 nanomole per liter as a cut point. But you can see more or less 2 on 10 people in general population have elevated Lp(a). In Africa, it's more marked. About 30% of the population could have elevated Lp(a). And for example, in Asia, in Eastern Asia, just 10%, in Latin America, 15%, etc. Here you are a more detailed comparison between different ethnicities. Again, the lower in Eastern Asia and the higher in African people, and in the middle, European, Latin American, Middle Eastern population, etc. So, Lp(a), we now know that it's an independent and genetic risk factor for cardiovascular disease. The observations came from meta-analysis and observational studies, Mendelian randomization studies, and genome-wide association study. And you can see in a very clear manner in this slide that the higher Lp(a), the higher. Lipoprotein, in summary, lipoprotein A is an independent risk factor. Increased level of Lp(a) are now recognized as an independent risk factor for ASCVD and calcified aortic stenosis. As I mentioned, the evidence comes from multiple observational and genetic studies. But interestingly, the levels are between 80 to 90% genetically determined. Is a genetic factor independent than other risk factors, including LDL cholesterol. And as I mentioned before, genetic and Mendelian randomization studies have shown that Lp(a) is now considered the most important genetic determinant for human life expectancy, and importantly, Lp(a) is a major contributor to residual risk. So here you can see in this cartoon the pathophysiology of Lp(a). In fact, we know regarding pathophysiology, but we do not know the true physiological role of Lp(a). Up to now, we can speculate that Lp(a) is an evolutionary lipoprotein only present in monkeys and in humans. So, due to ApoE has an important similarity with plasminogen, Lp(a) is pro-thrombotic, in fact, anti-fibrinolytic, also pro-inflammatory. I mentioned that is the major carrier of oxidized phospholipid, and also pro-atherogenic, including the development of aortic stenosis. Here you can see this is an image from our recent editorial in International Journal of Cardiology, comparing the contribution to valvular disease, or of course, Lp(a) is the major contributor, near 3 times in comparison with Lp(a). And in the middle, interesting, is VLDL contributing of about 45% regarding aortic stenosis. But it's also interesting, there are a lot of different studies showing the relative heterogeneity of Lp(a), and you can see here in this interesting trial or research, the ApoB related to Lp(a) is 6 times more atherogenic compared with the ApoB in LDL. Here you can see taken particle per particle. If you take 250 nanomole per liter of ApoB in comparison with the same amount of ApoB in LDL, of course, as I mentioned before, Lp(a) is more pro-inflammatory, heterogenic, is more dense, smaller, and antifibrinolytic. And the native LDL is not inflammatory unless it's oxidized. It's larger, less dense, not antifibrinolytic. So, but the very important thing in order to have a vision for the clinic is that the amount of LDL is by far huge in comparison with Lp(a), and for this reason is more heterogeneous in general, taking account that the ApoB that counts for Lp(a) is about the 10% in comparison with the ApoB related to LDL. So we mentioned that is genetically determined in 80 to 90%. There is a little influence in the levels related to chronic kidney disease, to liver disease that can reduce Lp(a), related to hypothyroidism that can elevate Lp(a), also in the menopausal period in the woman, and also in the acute inflammatory process. But the important thing for the clinic is that there is no changes in Lp(a) related to diet, to exercise, etc. I mean, to the modification of the bad lifestyles. So this is an important thing that we, when we use the assays in clinical practical. There is 2 type of measurements. We can measure in milligram per deciliter, and in this particular assay, we will measure the mass of Lp(a), and we can measure in nanomole per liter, and in this assay, we can measure particles. For this reason, it's more accurate to measure in particles, I mean in nanomoles per liter. Both are not well standardized measurements, and especially the mass assay is not well calibrated, but it is a work in progress. The science is trying to search for more accurate determination of Lp(a), but for clinical practice, both methods are valid, and for research is preferable the assay in nanomole per liter. Here you can see in this cartoon the particularity of different length of the ApoE. In the left, you can see the fewer Kringle 4 2 copies determine greater rate of hepatic production, and by the contrary, the more Kringle 4 2 copies determine a longer ApoE and a slower rate of hepatic production, and different, of course, levels in blood. Why we have to measure Lp(a)? First, new guidelines and consensus are asking for us because it's lifetime causal genetic factor for ASCVD. It's simple, it's not a fasting test. There is no critical added cost. And all tests that I mentioned before detect elevated LP(a). And finally, nowadays, patients want to know regarding LP(a). Here you can see several guidelines in the very left. All guidelines in general are in accord that at least one in a lifetime in an individual is okay. Here I'm presenting to you the awareness and knowledge global survey that is the manuscript is in preparation. It's a work that we performed with the ISCP. There were more than 700 answers, and the vast majority of the doctors and colleagues, pharmacists, etc., they mention or they believe that it's important to measure LP(a) at least once in lifetime, but interestingly, just 1/3 doctors participating in the survey knows his or her own value of LP(a). So, what is the real value of LP(a) in the context of several risk factors? This is an interesting work showing that in different colors, different in green low levels, in red very high levels, and you can see when you reduce the rest of the risk factors, you can reduce the risk regarding the level of LP(a). This is an important point for clinical practice. For sure, we will come back discussing this topic later. Treatment. What we know about. No standard therapies sufficiently reduce LP(a). There are several clinical trials ongoing with newer RNA-based drugs that significantly reduce LP(a) concentrations, like pelacarsen, olpasiran, zerlasiran, etc. And also muvalaplin is a very interesting small molecule that is oral, reduce LP(a) about 65%. The long-term risk of lowering LP(a) is unknown because, as I mentioned before, we do not know the physiological role of LP(a), and also if we reduce LP(a), we will reduce cardiovascular risk. We do not know yet. So, a little background regarding drugs. Niacin, the oldest lipid-lowering drug, has some effect, reducing 20% LP(a), but it's not in use anymore, the nicotinic acid, because the side effect. Aspirin we can use in primary prevention in order to try to reduce cardiovascular risk. There are some authors promoting the utilization, and some authors no, but it's a controversial topic up to date. Also, a drug in development, obicetrapib, is a CETP inhibitor, able to reduce near 60% LP(a). The PCSK9 inhibitors also reduce between 20-30% LP(a) levels, and in several trials like Odyssey with alirocumab. The author published that Lp(a), the reducing of Lp(a) contributed to 14% of the reduce in cardiovascular events in this particular clinical trial. We found with evolocumab near 40 to 50% in a particular population of near 1,000 diabetic patients, but the normal number of reduction of Lp(a) with ASCVD inhibitor is more or less 30%. Here you have an entire panorama. Statins do not modify Lp(a). In some case, may elevate a little bit. Also, nicotinic acid that I mentioned before, bempedoic acid, there is no effect. PCSK9 inhibitors I mentioned before. Inclisiran is similar, the effect like ASCVD inhibitor. And pelacarsen is an oligonucleotide antisense dedicated new drug in development that has very interesting effect, like the rest of the other newer therapies, olpasiran, serlaciran, lepodisiran, etc. All drugs are able to reduce near 100% the level of Lp(a). So, in conclusion, Lp(a) includes two protein components, ApoA and ApoB100. Is, as I mentioned before, the main transporter of oxidized phospholipids. The concentration is mainly regulated by the expression of the Lp(a) gene. A significant ethnic difference in Lp(a) levels and different distribution at the population level. Many epidemiological, clinical, and genetical studies demonstrate that there is a close relationship between Lp(a) and cardiovascular risk in general. Lack of a standardization of the assay is an additional impediment, and we do not have well-established treatment available. Finally, is now Lp(a) recognized as independent risk factor for ASCVD and calcified aortic stenosis. For the first time, we will have specific and very effective drugs in development to treat Lp(a), elevated Lp(a). Studies with cardiovascular events are in development. For example, the Horizon trial is going to finish next year. The olpasiran trial is going to finish in 2027, etc. But if positive results are finally confirmed, there will be a great step forward and a new opportunity for cardiovascular prevention. Many thanks.
Thank you, Professor Lorenzetti, for the introduction about the lipoprotein A. What's the structure like, how they are linked to the cardiovascular risk, and more importantly, what are the treatment available, which is apparently still ongoing. In the meantime, we would like to conduct calling questions to see how you are managing these patients in the meantime. We are pulling up the poll from Zoom. Feel free to participate. Look forward to your response, because that could help to shape our upcoming panel discussion as well. So let's spend a minute or two to see when do you most often order lipoprotein A test in your primary prevention? What is your biggest barrier for ordering the lipoprotein A testing? Let's wait a bit. What the respond before we move on to the clinical case discussion. I know that some of you may have some question. I saw some Q&A already. Feel free to type in the chat, in the Q&A boxes. We can address that towards the end of the lecture. Looking forward to your questions. Not sure how the polling is going.
We're still receiving some answers.
Thank you. In the meantime, while we are waiting, why don't we invite our panelists, Dr. Low and Professor Dixon, to join the panelists so that we can start on discussing the potential question and also the case. To begin with, I'm actually very surprised that one of my colleagues told me he got an elevated lipoprotein A. So I'm not sure in your practice, how often do you see a doctor or how often do you actually order a lipoprotein A test? Dr. Loeb, do you have any insight for us?
Yeah, I think that all doctors and healthcare workers are susceptible to the same risk factors as the general public. So we all should test LPA regardless of our job. I do test it regularly because I take it as a equivalent risk factor. Working in a hospital with a lot of heart attack and stroke is important to integrate into our pathways. So in my hospital, in Changi General Hospital, we have integrated that all patients who had heart attack or stroke actually get LPA tested. But the idea is, as a primary prevention, we want to also, find ways to integrate that to people who are intermediate risk and reduce their risk.
Right. What about you, Professor Dixon? How often do you see a doctor ordering a lipoprotein A test, or is it feasible to order a test from a pharmacist instead?
Yes. So given our collaborative practice opportunities here in the United States, all 50 states, pharmacists can enter into collaborative practice with a physician or advanced practice provider in some states as well to order labs and medications, et cetera. So in my clinic, most patients are getting their Lp(a) screened. With that said, here in the United States, we do at times run into insurance coverage issues, given the complexity of our healthcare system as it relates to insurance coverage. So many insurance companies still consider Lp(a) testing to be experimental, which is incredibly frustrating when we're trying to screen patients. So I would say that's a big barrier, along with really getting the broader medical community to routinely screen. I would say that we still have a lot of work to do.
Right. I'm just curious, what is the turnaround time for your laboratory to get the lipoprotein A done? I mean, it's not something that is urgent, but I'm just curious because in Hong Kong, it may take a bit of time because it's not something routinely done in the laboratory.
How long is that in Hong Kong, you're saying? Is it a few hours or a few days?
Probably a week.
Oh, okay.
Usually it takes
Well, if it's integrated into the hospital lab, it's quite fast, so you can get it in 1.5 hours or less.
Yeah, for us, it's a send out lab. And so I say somewhere in the 7 to 10 day range.
Right. Yeah, I think that's similar in Hong Kong as well, because not every lab has the capacity to actually do the lipoprotein A screening. So I feel like we got the result from
Professor
the
Chen,
polling.
just let me comment.
Oh, sorry, Professor.
In my case, the major problem is that LP(a) is not covered by the Social Security. The patient has to pay for the assay. Everything is covered, the rest of the assays, especially the lipid panel, but LP(a) is generally not covered, and the patient has to pay for this analysis.
Right. I think that actually a lot of the participants share something similar. It's about the limitedness or cost issues. Similar to the case in US, that's about the insurance. Similar to the case in Argentina about the coverage as well. But I think if that's available, it seems that most of us will be doing the LPA screening quite regularly. So why don't we move on to the cases? We prepared 2 cases tonight to talk about. So for the very first case, that would be a middle-aged, sorry. So we continue waiting for the case to be pulled out now. So for case number 1, we got a male, 52 years old with a South Asian high-stress job with a BMI of 28 kilogram per meter square. I've got a significant family history about father with a myocardial infarction and also brother with stenting at 49. And the home blood pressure is not that high, 130 with a diastolic of 80. Cholesterol-wise, is 6.2 millimole per liter with slightly elevated LDL-C, 4.0 millimole, and also significantly elevated lipoprotein A. And his diabetic control is fair with a slightly high CAC score. So with this patient who is not taking any medication at the moment, what would be the best treatment for this patient? Are we going to start statin or even PCSK9 inhibitors, or are we trying to do some lifestyle modification first? What's your opinion, Professor Dixon?
So for me, what really jumps out is this individual's CAC score of 450. And I think that there's at least some growing consensus that that's somewhat equivalent to subclinical atherosclerosis, right? So that combined with the elevated LDL and LP(a), I think it's safe to say this patient is at high risk and warrants treatment. Lifestyle, of course, is always a part of any intervention to reduce ASCVD risk. As discussed in the presentation, the lifestyle approach isn't going to do much for the LP(a). So I think a high-intensity statin would certainly be warranted here. I do think that there's emerging data now with using PCSK9 monoclonal antibodies in some of these high-risk patients that haven't had an event yet. And I think it's easy to look and see the LP(a) and want to go straight to the PCSK9 mAb, but I would say that the general reduction in LP(a) that you get with those therapies, there's some evidence to suggest that that may not be sufficient to really move the needle in terms of LP(a) mediated risk. So I would start with a high intensity statin and go from there.
So what would be your target of so if we start on statin, it's very unlikely that we're going to lower the lipoprotein A. So in that case, we're aiming for 50% reduction of the LDL-C, or we are aiming a little bit further down to less than 2.0 millimole per liter. What would be your treatment option, Dr. Low?
Okay, I'll go first and then Professor Alberto can go next. So I agree with what Dave said. This patient is at high risk, but actually I would categorize him further. He's actually very high risk because he already has subclinical atherosclerosis. 450 is very high. It's definitely more than 90% for his age. And he has a very strong family history. Now, he's 52. His father had heart attack at 54. and his brother had a stent at 49. So this is a patient waiting to have a heart attack anytime, any day. So this makes us very worried. We need to do cardiac assessment to see whether does he have symptoms or chest pain or angina, and we need to treat aggressively. So aggressive treatment is very important, and that is multi disciplinary. I created this framework called the LILAC, and I use that regularly in my clinic. Just going to quickly go through that in a minute. So first is L. So L would be, I want to establish his cardiovascular risk, and we already said he's very high risk of having an event in the next 5 to 10 years. And then I would be, we want to tell him to stress to improve his life factor. And I think he points out that he has very high stress job, whichever that may be. He has to try to reduce that, sleep well, don't smoke and drink alcohol, which we don't have in this history. And then L will be to lower the LDL, and I will tell him to go down to less than 1.8 millimole per liter, possibly go even lower to 1.4 after we do some more cardiac assessment. And then A will be assessed, and also consider aspirin for him. The LPM being very high at 400, the subclinical atherosclerosis being present, we can discuss about aspirin, but we have to weigh his risk of bleeding. And then C will be cascade, because there's very high risk of a genetic kind of inheritance with a very high LP of 400, is about 50% chance of passing it down. So that's how I use LILAC framework for this case. Over to you.
I always
Professor
love your
Alberto.
I always love your framework, LILAC. I
Thank
think
you.
I first heard that in the other conference, and I think that is a very nice framework to memorize. But yeah, absolutely agree that the LDL-C probably high. Agree with Dave and also Wang as well. We want to start high intensity statin and go from there. Probably monotherapy may not be sufficient for Mr. Aris. Do you agree, Professor Lorenzetti?
Yeah, I agree. In this particular case, that you have two very important things here. The family history is significant, and also the patient has, as the colleagues mentioned before, atherosclerosis related to the calcium score. The LDL target in this patient probably may be less than 70 and even more, less than 55 milligrams per deciliter. In this case, we need a combination of a statin plus ezetimibe in order to reduce, 60% the LDL level. If after that we do not achieve to the target, probably the addition of PCSK9 inhibitor, maybe a monoclonal antibody or inclisiran, could be a good opportunity.
Do you have any preferences about PCSK9 inhibitors versus inclisiran, or they are pretty much equivalent in terms of LDL-C reduction and also lipoprotein A reduction?
It's a very, very good question. I would say I have a lot of experience. I am one of the co-author of the recently published Vesalius study. The monoclonal antibodies are very effective and able to reduce more than 60% LDL and also 20-30% Lp(a). The problem is the administration. The patient needs to have an injection every two weeks. Maybe inclisiran a good alternative if the patient has a lot of trouble with the day-by-day life, etc. You understand that. But if there is any problem in this regard, probably the monoclonal antibody will be slightly better. But in general, there is no big difference between the two interventions.
Right. I think one of the things that we can show to the patient, because sometimes it's very difficult for me to convince the patients to start on medication for primary prevention because they're not quite sure about their risk. So I think one of the great tools would be to visualize their cardiovascular risk, which is available with some online tools. For the next slide, we can illustrate that for Mr. Aris, even without the lipoprotein A, he got a high chance of lifetime cardiovascular risk anyway because of the family history, because of the LDL level. But with the elevated lipoprotein A, the risk actually doubles, basically at every single time points. I think that would be a very important way to ensure our patient to adhere their treatment and to start primary prevention with these kind of graphics, to let them know their risk and also to illustrate that how the pharmacological therapy would be useful for them. So moving on to the next case, we're talking about a relatively healthier patient who is a 40-year-old lady. He's actually a marathon runner, very healthy diet with BMI 22. Her mother does have a high cholesterol level and grandfather got a stroke in his 60s. His home BP is relatively is well managed and with actually slightly elevated LDL-C for this case and mildly elevated lipoprotein A. So with these relatively younger and also healthier ladies, would the management be very different, Professor Dixon?
These are tough patients, where there's a lot of good news here, right? In terms of, obviously, this is an individual that has presumably a pretty impeccable lifestyle, and the lifestyle aspect, is great. And then from a lipid panel perspective, a somewhat average type of lipid panel, the LDL, I think we would probably agree today that 130 is high. Right? Is it in that upper tier of 160 or 190? Of course not. And then the Lp(a) there, right on the cusp of what we might consider to be intermediately elevated. And I don't even quite know what that means yet from a clinical perspective. I think any level of Lp(a), if as you get into that intermediate range, is not good. A normal CRP, and then importantly here, a CAC score of 0. And so I think this is an individual where shared decision-making and understanding what the patient's, wishes are, what are they concerned about long-term. Because anytime we talk about primary prevention and using pharmacological interventions, it's really important to help to have patients understand that they're needing to commit to long-term, potentially lifetime, therapy. And so I don't think that's a decision that we should necessarily rush into in cases like this. I think there's a couple of options in terms of, do we wait and repeat, the CAC score in 5 to 10 years? We don't have a clear answer yet in terms of what is the right interval, especially if this is a patient that is, say, very much against pharmacological intervention. But I wouldn't say that CAC score of 0 would buy her, a lifetime freedom from atherosclerosis, right? Because of the age, given that she's quite young at 40 years of age. So that's kind of my initial assessment, but I'd love to hear from the other panelists.
Yeah, what about you, Professor Lorenzetti? What's your plan of management for this patient? And more specifically, when would you like to see this patient again after the very first consultation?
Yes. First of all, I want to say that, as my colleague mentioned before, she's a young lady. CAC 0 is not a guarantee because the plaque may have just all cholesterol and not calcium at this age, and there is again not a total guarantee of there is no atherosclerosis. So I would try to find subclinical atherosclerosis. I mean, in the legs, in the femoral arteries, in the carotid, arteries in terms of ultrasound, trying to screening with ultrasound. If not appear nothing regarding atherosclerosis or suspected of atherosclerosis, I would try to reduce 130 milligrams per deciliter of LDL, probably given a small doses of statin, because I will feel more comfortable with LDL below 100. Probably 10 milligrams, 5 milligrams, even 5 milligrams of rosuvastatin, for example, could be an alternative. But the other vision regarding not to do anything by now and screening in the next few years, a re-screening in the next few years would be a reasonable alternative as well. But in my case, I do prefer try to find subclinical atherosclerosis rather than calcium score. And after that, an alternative may be to reduce a little bit LDL.
Right. It's kind of surprising to hear you will be using rosuvastatin anyway. What about the case in Singapore? Are we going to use a rosuvastatin, or you will start off with some even milder treatment like simvastatin?
Okay, I'm going to go and use the LILAC framework again so that we get our audience in understanding the holistic manner. So first is the L will be to understand what is the cardiovascular risk if this lipid causing, so L for the lipids. So we understand the LDL is 3.4, which is generally okay, but it could be better as both professor has mentioned, to be less than 2.6 millimole per liter or less than 100 would be actually the better half of the population. She actually has no other risk factors at this moment, and a negative calcium score is reassuring, but we know that could be falsely negative at her age. So we need to ask her for more risk factors, like asking if she did have a normal pregnancy, did she have a gestational diabetes, did she have a preeclampsia, things like that. Assuming everything is good and there's no significant family history that we can note here, we go to I. We will stress on her to continue to improve her lifestyle, because we're trying to do a primary prevention for a long time. For the next, talking about lifetime cardiovascular risk reduction. And using that LP calculator that Franco showed, which is actually freely available online, an LP calculator created by Brian Ferris and his group, that her lifetime cardiovascular risk is 9.3% if we didn't include LPA. When we include the LPA, it becomes 13.8%. So still very low, but 13.8% for her whole life, up to 80 years old, to have a cardiovascular risk. So this risk really goes up at the menopause age. So after menopause, the risk therefore divides, where if you have high LPA versus low LPA. Her LPA is a bit high, so it's more than 125 nanomole per liter or 50 mg per deciliter. So that is a risk factor. So we want to use that to tell her the next L, which is to lower the LDL, using that to motivate her to either reduce her kind of cholesterol diet, as well exercise more and healthy, maybe alcohol and things. You can try to do that without statins first. Otherwise, I would agree, to start statin or any other lipid-lowering treatment to bring down to about less than 2.6 millimole per liter. And then come for A and C, assessment of cascade is not so relevant here because it's not very high, but can be considered and can be discussed with her on a case-to-case basis. That's what I would do.
Thank you, Dr. Low. I think on the next slide, we actually got the graph as well to demonstrate how age actually related to the cardiovascular risk. As mentioned, with a lot of with the panelists, I would say it's an exponential increase after the age of 60. It's escalates pretty quickly with the lipoprotein A and also with the LDL level and also with the age. That's why a lot of time the continuous monitoring, the follow-up period would be so vital for patient for primary prevention. Even if the patient doesn't have a high risk at this moment because of the young age, it is very likely we will need some kind of intervention before the age of 18 for the primary prevention. Thank you again for your for the discussion. It was very nice to talk about a relatively case, the ladies, and also with a more prominent case that does require combination therapy and likely PCSK9 inhibitors in the future. So let's move on to the Q&A, see if there is any question we'd like to address. I got a very early question at the start of our discussion is about the use of vitamin C. So what is your experience in using high-dose vitamin C? Is that a viable primary prevention strategy for people with elevated lipoprotein A? I'm not sure. I'm pretty sure it's not a standard therapy now, but I'm not sure if you guys use that clinically for patients with elevated lipoprotein A, given that we don't have a lot of treatment available now.
To my knowledge, I don't believe that high dose vitamin C has been shown to lower Lp(a). I think there's this theoretical possibility of making Lp(a) less sticky or atherogenic, but I don't think that evidence is anywhere near where it would need to be for me to use that in practice.
I do agree also.
What about you? Yeah. So it doesn't actually help. What about you, Dr. Low?
Not necessarily. Yeah.
So maybe as a supplement, probably it won't be harmful to the patient, but in terms of clinically usefulness, that probably isn't it. Another question is that the clinical trials, well, lipoprotein A targeted drugs like the antisense or siRNA or PCSK9 inhibitors achieve meaningful lipoprotein A reduction. What are the adverse events have been observed, and do they raise any concern about suppressing the Lp(a) in physiological role? I'm not sure if Dr. Low want to take that question first. Is there any adverse events that you have observed?
We are waiting for the trials to let us know, because the trials that the siRNA particularly can lower down to 99%. So it's really amazing. And some even have the effect for more than 6 months. So we need to see actually is there any long-term side effect. There is some slight concern about this increased risk of diabetes, or actually increased risk of bleeding, but I don't think we have anything to speculate until the results come out. Yeah.
What about you, Professor Lorenzetti? Do you think that suppressing the Lp(a) would affect any potential physiological role?
No. I agree with Dr. Low.
Professor Dixon, do you have anything to add?
Not really. I mean, I think the only, with these Lp(a) lowering therapies that are in development being injectable therapies, of course, injection site reactions can occur, but that I think would be expected. So I think it's the evidence we have so far from the early trials, do not show any strong safety signals, but I certainly agree that that's where longer term trials are going to be really important.
Right. And probably some post-marketing trial would be needed to for the surveillance purposes and also for the pharmacovigilance purposes. The other thing I actually want to ask as well is about the relationship between the familial hypercholesterolemia and elevated lipoprotein A. Do they share this pretty similar genetics, or is there any prevalence of the co-inheritance? I believe both has an impact on the ASCVD risk. Would that be a synergistic, not a synergistic in a good way, but would that be an additive risk for the ASCVD? Professor Dixon?
So there's definitely some overlap if you look at FH and elevated Lp(a), which I think would suggest that they aren't probably completely independent or separated. And obviously, when you have that overlapping risk, as you look at, kind of the odds ratio for ASCVD and ASCVD related mortality, it increases exponentially. So unfortunately, I think we're still struggling to appropriately identify patients with FH, right? When we think about screening, and to kind of add to that, also screening for Lp(a), I think that's really where we just have to invest a tremendous amount of public health efforts to kind of raise public awareness among the general public. I do have more patients coming in, asking to be screened than I've ever had before, but it's still pretty rare that someone comes in. I don't think we can just wait for the medical community necessarily. Because that overlapping risk, those patients are ones where, I'm incredibly concerned about, and certainly we have to be quite aggressive with interventions in those patients.
Right. I'm afraid that I'm not sure if Dr. Low and Professor Lauren-Sandy, do you have anything to add about the familial?
Yes.
Sorry.
Thanks, Professor Cheng. There is an important overlapping between FH and elevated Lp(a). Probably there is some synergistic risk in this regard, but there is no a specific way, at least described or discovered regarding this association. But probably a patient with FH and elevated Lp(a) will have a benefit when we have available the new medications that are in development. But the interesting thing is people with elevated Lp(a) is unusual to have. In the opposite way, people with a low Lp(a) level has no association with diabetes, and also patients with familial hypercholesterolemia are also not associated with diabetes. This is a link probably that is a part of some things that we have to know regarding the LDL receptor, but it's a matter of investigation.
Right. I'm sorry. I would love to hear your opinion from Dr. Low as well before we move on. Please, just a few words would be nice.
Well, I think we had a wonderful session. We're talking about Lp(a), which is a lifelong genetic risk factor, and then also FH, another lifelong risk factor for high LDL. So putting two and two together, that really does double or triple the risk. So whichever it is, all FH should have Lp(a) check, and all high LDL should be considered to have FH if they meet the criteria. So that's all.
I'm so sorry. Yeah, I'm so sorry for the rush, but I'm afraid that's all we've got for today. Before we close, I'd like to thank our outstanding speaker, Professor Lauren-Sandy, Dr. Low, and also Professor Dixon for an exceptionally rich, practical, and forward-looking discussion. Today's section reminds us 3 key points. We need to screen more strategically. Elevated lipoprotein A lies in plain sight. We must optimize all modifiable risk factors, especially while we are waiting targeted lipoprotein A lowering therapies. And the future is coming really fast. We have a lot of drugs on the pipeline that will reshape the prevention, and now is the time to prepare our clinical pathways. Once again, this webinar will be available shortly on the ISCP website, and we encourage you to share it with your colleagues. Please consider joining the ISCP to rewatch this and all webinars in our content library, which is growing every week. You can scan the QR code to see these you see on the screen and go to our main links and learn more about ISCP and sign up. We want to thank our team at ISCP for organizing the activity today. And finally, our thanks to you, our audience, for joining us. We hope that you have found it insightful and helpful for your everyday practice. Don't forget to complete the short survey as soon as we finish here. To make sure you sign up to receive our newsletter and updates on our educational activities. And of course, follow us on social media at ISCP Cardio, the easiest, most effective way of staying up to date on all ISCP events. On behalf of the ISCP, we wish you an excellent day and look forward to seeing you at our next event. Thank you and goodbye.